This is a review of the respiratory system and just a reminder of some key concepts that will come in handy as we talk about respiratory failure and ventilators. So here are our learning outcomes. We will basically be going over these major concepts of ventilation and oxygenation. So as you can recall, the purpose of the lungs is really to exchange gas. We're taking in oxygen, we're getting rid of carbon dioxide. So these are very basic concepts, but just to remember, your upper airway is in charge of warming the air, conducting the air into the lower airway, humidifying the air, etc. So if we think about that, it feels pretty basic, but if I were to put somebody on a ventilator and bypass their upper airway and go straight into their lungs and straight into their trachea, I am no longer warming, I am no longer humidifying, I'm no longer filtering the air. So these are key things to remind ourselves of as we learn about more advanced respiratory failures and mechanical ventilation. What should normally happen and how is that changing? So another review of your anatomy and physiology, we need to be aware of where the carina is when we're looking at invasive ventilation. So if you look here, you can see where that black arrow is. It's basically that forking off of the right main bronchus and the left main bronchus, those two primary bronchi. So when the trachea splits off into the right main and the left main, that little notch, that little V that it creates is the carina. And why is the carina so important? Well, as you recall, it causes the cough reflex. So if I were to put something in this patient's mouth and into their trachea and it went too far and started to tickle the carina, they're going to be constantly coughing. So something to be aware of when we start to put invasive devices in our patients. So some key concepts here to be aware of is that breathing is work, physical labor. So we have a term called work of breathing, and that's basically just the amount of effort or the amount of energy needed to move your lungs, to get your lungs to push out CO2 and to take in oxygen. And what happens if in a normal patient who's retaining CO2, meaning they're breathing really, really slow, and they are not blowing off that CO2 how they're supposed to, they're not getting rid of that CO2, and the CO2 in their blood starts to rise, it should actually stimulate them to take more breaths. It should stimulate them to breathe. That's in a normal patient. So this can become a vicious cycle because if a patient has to work to breathe, which in a very decompensated, a very sick patient, it's effort to breathe. You have to work, so you need oxygen. You're using muscles, intercostal muscles, your diaphragm, etc. So if you need oxygen to work, but you're having a hard time breathing, then you can't get the oxygen that you need to work to breathe. If that makes sense. So you've got a vicious cycle here. So that's how patients who have respiratory failure decompensate fairly quickly. And down here at the bottom, you can see an example of ventilation. Ventilation is not just breathing. When I think of breathing, I think of oxygen, I think of CO2, I think of the amount of oxygen in the air, I think of all these other things. Ventilation is a lot more specific. Ventilation is the movement of air. So the movement of CO2, the movement of oxygen in and out of the alveoli, the movement of the lungs. So some things to be thinking of when we're talking about patients who have problems. Do they have a ventilation problem? Are they having too much effort? Do they require too much effort to breathe? And so on. So we've talked about work of breathing, the effort it takes to breathe, and we've talked about ventilation, that movement of gases. But now let's talk about the lungs themselves. So if I'm looking at a pair of lungs, a very healthy set of lungs, they're going to have good compliance. And what that means is that they have just the right amount of stretch. When I give them oxygen and when I push air into those lungs, they have enough resistance so that they don't just flop open, but they don't have so much resistance that they don't let any air in. Think of it as a stretchy rubber glove that you could inflate it fairly easily, but it'll deflate pretty quickly too. It has a nice rubber band feel. When you look at low compliance, now we're talking about very stiff, very rigid lungs. Really hard to get air into those lungs. Also, because they have low compliance, it's probably hard to get air out as well. They're very stiff and rigid. Then when I look at high compliance, these are lungs that are really stretched out and have no bounce anymore. Think of a stretched out rubber band or this spring over here that can't really bounce anymore. It's just stretched out. It can fill up with air all day, but it can't really get it out, so air begins to trap in the lungs. Another concept we need to look at here is diffusion. This is something you learned about quite a while ago, but diffusion is basically CO2 and oxygen moving at the capillary membrane level, excuse me. So when you have capillaries maybe next to an alveoli, gases are going to diffuse according to the pressure. So if I have a lot of oxygen in my alveoli and not a lot of oxygen in my vessel, in my capillary, then that oxygen is going to move to the area of lower concentration, concept of diffusion. It's going to go with the concentration gradient. So that oxygen is going to gravitate to that low amount of oxygen because it wants to balance things out. Same thing happens with CO2. And then when we look at resistance, it's just what it says. It's anything that's resisting the gases to flow. So for instance, if you have a stuffy nose, that's resistance right there. Somebody who has a very long airway, like think of a giraffe, that's a lot of resistance that the air has to meet before it finally gets to the lungs. Versus a very short airway, like a little bird. Think of a little bird airway that's very small. It just has to go right into the airway and then into the lungs. A lot less resistance. If we think about the diameter of the airway, if you think about a big tube and getting air to go through that tube versus a straw, the straw has a lot more resistance. So length and width have a lot to do with the amount of resistance air is going to meet. So we've talked about ventilation, which is movement of gases. And to ventilate, I have to have muscles. I have to move my lungs. I have to have a brain to tell me to breathe. I have to have the strength and the capacity to breathe. But when I'm talking about oxygenation, we're talking about it on a much smaller scale. We're talking about gas exchange. So when we look at this smaller scale, right here we're looking at one alveolus and one capillary. And this is the demonstration of oxygenation in that we're looking at the ability of CO2 coming from the pulmonary artery getting out into the lungs so we can blow it off because we want to get rid of CO2. And also we're looking at the ability of oxygen to travel from the alveolus into the pulmonary vein. So things that might cause a problem here, for instance, if you have pneumonia, you have all this junk in your alveolus and the oxygen can't really get through all of that junk because there's a barrier there. It has to travel further. So a ventilation problem has to do with physical strength and movement of the muscles around your lungs, so your intercostal muscles and your diaphragm, also your brain, your ability to actually breathe. And oxygenation has to do with a more pathophysiological approach in terms of looking at the alveolus, problems with the alveoli, problems with the artery, problems with the veins. So let's take a little bit more time on this. If I look at a alveolar capillary unit, so one alveolus and one capillary. This is just like a microcosm of what's going on in the lungs all the time. I have an alveolus, and I've just taken a deep breath, and I've inhaled oxygen, and that oxygen is going to eventually transfer into the capillary. Now, if you can see here, I've got my pulmonary artery, and I have unoxygenated blood traveling to that alveolus. It's going to exchange CO2, get rid of CO2, and take in oxygen. So again, you can see how if there's a problem with the capillary or a problem with the alveolus, we may have an oxygenation issue. When you look at the SaO2 or the saturation of oxygen, that's the amount of oxygen that is in your blood. So it's the oxygen that's actually bound to hemoglobin, and we express it as a percentage. So your SaO2, your saturation O2, SaO2 is the amount of hemoglobin, the percentage of hemoglobin that has oxygen bound to it. So what percentage of your hemoglobin is saturated with oxygen? And this is a number you're probably very used to. It should be above 95. Sometimes in the ICU we're happy if it's above 90. So just to be aware, when we're looking at that number, it's how much oxygen got from the lungs into the blood and attached to the hemoglobin.
When we have failure of oxygenation, we're looking at an issue where not enough oxygen is getting to the blood. We have a failure to oxygenate. So there's a number of different ways our patients can fail to oxygenate. Now looking at our list here, we may see hypoventilation, something called VQ mismatch, and something called diffusion limitation. So let's look at hypoventilation first. So if our failure is to oxygenate, to get oxygen into the blood, The problem could simply be that our patient is not breathing enough. They're hypoventilating, breathing at a rate of 6, let's say. So this would result in our patient not taking in enough air overall, and that's going to mean that we're also not going to take in enough oxygen overall. Now next we have what's called VQ mismatch, and this can be a little bit confusing, but essentially the V stands for ventilation and the Q stands for perfusion. Now ideally we would have a great match. We would have great ventilation, great working lungs, moving a lot of air, and we would have great perfusion, great blood flow, and those capillaries are reaching all those alveoli and picking up all of that oxygen. So to have good VQ matching, we have to have good working lungs, good ventilation, and we have to have good perfusion, good blood flow to those lungs. Now when we see a mismatch, either bad ventilation or bad blood flow, now we're not going to be able to get oxygen into the bloodstream as well, and we have failure to oxygenate. So VQ mismatch is an umbrella term. It's going to describe any mismatch in ventilation and perfusion. Now that naturally actually happens in our upper airways. We have great ventilation and movement of air in our upper airway near the apex of our lungs, but our blood flow is not quite as great up there. The density of capillaries is a little bit lower. So we will see some natural VQ mismatch, just regionally speaking and anatomically speaking. However, what might cause a more pathological VQ mismatch when we might actually have a more significant impairment in ventilation or perfusion? Well, when we have a ventilation problem, let's say pulmonary edema, we call this type of VQ mismatching shunting. So in a sense, shunting occurs when you have blood flowing, the blood is fine, our perfusion is fine, but it's not participating in any gas exchange, so we have a ventilation problem. Now shunt is a type of VQ mismatch where blood is flowing, we have our Q is fine, but there's a ventilation issue. But what about when our lungs are fine, we have a good V, but our perfusion is the problem? So an example of this would be a pulmonary embolism, where a patient's actual lungs and lung movement is just fine, we have a good V, but we can't get blood flow to those oxygen-rich lungs. So that's another type of VQ mismatch. Now we have a bad Q or a perfusion problem, where the Q is not matching the V. Now last we have what's called a diffusion limitation or diffusion defect, and this is referring to that space between the capillary and the alveolus. So we need those two to have good contact. We need the oxygen from the alveolus to get into the capillary, into the bloodstream to oxygenate. But in diffusion limitation, that space between the alveolus and the capillary is thickened or damaged, so that now that normal pathway of oxygen is actually limited. So some examples of this are pulmonary fibrosis or even interstitial edema, which makes the oxygen's journey from alveolus to capillary much more difficult.
Other issues with oxygenation, one of them is low cardiac output. And if you think about it, this is kind of a blood vessel problem. This is a perfusion problem. I could be breathing just fine, but if I can't get my blood to my lungs to get oxygenated, that would be a problem with oxygenation. So something like congestive heart failure. Also somebody who has a low hemoglobin level. Again, this is a blood problem. I'm breathing just fine, I'm breathing in plenty of oxygen, but the blood that I'm transporting past the lungs and past the alveoli to gobble up this oxygen is very low in hemoglobin, so I can't really latch on to very much oxygen. Another example of that would be a GI bleed, somebody who's just lost a lot of blood, somebody who's anemic. There's not a lot of blood in the body, so there's not a lot of blood to become oxygenated. Another issue is tissue hypoxia. So there's certain conditions that prevent certain tissues from using oxygen. So we may say have a patient who's breathing just fine and has good blood flow, but the body's chemistry, because of maybe cyanide or CO poisoning, carbon monoxide poisoning, they are not able to actually use that oxygen. So again, that would cause an oxygenation problem. So here we can see how hypoventilation causes failure of oxygenation. So they're not breathing in enough oxygen, therefore the blood is never going to get enough oxygen. And in these patients who are hypoventilating, breathing at 6 a minute, breathing at 4 a minute, these patients are not breathing in enough oxygen, but they're also not breathing out enough CO2. so the CO2 begins to build up in their blood, and therefore we start to have more acids caused by a respiratory issue. So this patient would have respiratory acidosis. So we need to be thinking about what are all the things that can cause hypoventilation. Any kind of CNS depressant, alcohol, even a neurological disorder, even somebody who has a neuromuscular disorder like ALS, all of these can cause hypoventilation.
Now looking at VQ mismatch, we remember that we need our quality ventilation, our effective breathing, to match our quality blood flow, our good blood flow. We need V and Q to match. So as we discussed, one example of VQ mismatch is when the V is fine, but the Q is not. So the ventilation is effective and the alveoli are moving well and they're inflating and they're full of oxygen, but we have a perfusion problem, we have a Q problem, and we can't get that blood to the alveolus. And this type of VQ mismatch, where we have bad perfusion, is most commonly caused by a pulmonary embolism. So you can see here, there's plenty of oxygen sitting in that alveolus, ready to be diffused into the bloodstream, but we have a big clot blocking the blood from even getting there. So a PE is a very common cause of VQ mismatch. Now next we'll talk about the other type of VQ mismatch where the V is the problem and we have a ventilation issue.
So here's our picture of intrapulmonary shunting. You notice that our vessel looks fine. We have good flow, the vessel looks healthy, but something is wrong with that alveolus. So remember, it takes two to oxygenate. You have to have good blood flow and you have to have a good healthy alveolus. So in this case, we have a diseased alveolus. Maybe they have pneumonia, maybe they have poor ventilation, maybe they're just taking short breaths and they have atelectasis in this case. Therefore, I can have all the O2 in the world in this collapsed alveolus, but it's not going to get to my vessel, get to my capillary as efficiently because look at all that distance there. So we need to have healthy alveolus and healthy blood vessels to transport oxygen. So people usually understand hypoventilation and even intrapulmonary shunting and VQ mismatch in terms of both of them having to work or the patient having to breathe well. But diffusion defect tends to confuse people sometimes. And the best way to remember this one is that you may have a good alveolus and you may have good blood flow, but the barrier between them is too thick. And that is a diffusion defect. So the oxygen, like it says here, needs to move across the membrane, needs to pass that membrane. But if it's too thick, like if somebody who has fibrosis, or if there's too much fluid, like our patient with left-sided heart failure and fluids backing up into the lungs, and we have pulmonary edema, then we can't exchange oxygen as well, and it's defective. So somebody who has diffusion defect and who has had it for a long time will have hypercapnia or high CO2, and that's more of a late sign of diffusion defect.